So thanks very much for joining me on this update of the Australian Diabetes High-Risk Foot Service database. It's all in the numbers. I'd like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional custodians of the lands on which we are meeting today. And for me, that's the Gadigal people of the Eora Nation. We acknowledge that they have occupied and cared for these lands over countless generations, and we celebrate their continuing contribution to country across Australia. Aboriginal and Torres Strait Islander people have a particularly high burden related to diabetes foot disease, and I think data collection is an important part to improving outcomes for this population. So in overview, we'll be looking at the project objectives, onboarding of services, feedback from live sites, some of the challenges, and then we'll be using the audit tool to have a look at some cohort characteristics and announcing the Charcot Foot module. And for those that are not familiar with the project, a lot of the background information is available at the website, as is the contact information. So with respect to objectives, the primary objective was to develop a standardised Australian data repository for high-risk foot services, and we're well on our way to achieving that. Secondary objectives were to evaluate service and clinical outcomes, to perform national benchmarking, to provide reports to participating services, and to establish a platform for local and collaborative research. Now, we are well on our way to achieving those last two, in that we've provided to the live sites interim reports for 2021, and we now have this longitudinal data repository, which will undoubtedly become useful for collaborative research in the future. We have had 31 expressions of interest over the last 2 years since this was first announced, and 18 now have ethics approval, and 7 of these sites are live. And live meaning that they've worked through their governance applications, they have active databases, and they're able to start collecting data. So there's the 7 sites represented there. And for any up-to-date information on the sites participating, you can visit the link to the Google map shown there. So with regard to feedback, I did survey 4 of the first live sites as shown, and the median time that they reported spending on the governance application was about 4.5 hours. Keeping in mind the ethics application is actually taken care of centrally. So overall, they rated the following areas as have been satisfied or very satisfied. So they were accessibility and comprehensiveness of project documents. So we have a OneDrive where all the resources related to the project are stored and kept up to date. The ethics approval process. So again, this is under a national umbrella ethics called National Mutual Acceptance, and this applies to all states and territories with the exception of the Northern Territory. And I'm very happy that in the Northern Territory we now have 2 sites actively pursuing ethics applications. The governance or site-specific approval process is really led by the site itself, and then timeliness and usefulness of support from the NADC. And I'd certainly like to hope that anyone interested in taking part in this database or who is already working through the stages, that they feel very comfortable reaching out for support from myself. So the median time spent on entering a new record is 17.5 minutes. So keep in mind a new record will represent a new episode of care that's going to last several months, if not even a year. And that little updates as you go longitudinally are required, but really the bulk of information is entered at the beginning. Also, when that patient ultimately has further episodes of care, a lot of the replicated data is prompted. So there'll be time saved on subsequent entries for that particular record. And also familiarity, as we gain familiarity with data entry, I'd anticipate that that time would reduce. But there you go, 17.5 minutes for a new record. Satisfaction with the process overall, again, generally satisfied or very satisfied, and that is in the domains of database setup, process and support, the minimum data set itself, so the fields that are required, and flexibility to meet the service's needs. So we do have some server options depending on what suits the service and what's available to them. and user setup options, as well as the ability to add data fields that are particularly relevant to that site. And then the data entry process itself, admittedly, is always going to be a little bit dry. The benefits that these services have identified is being able to audit and being able to ensure they're providing a good service and making improvements in service provision, ultimately being able to build the regional profile and then benchmark regionally, but also nationally. But REDCap also gives you a way of being able to rapidly access information so you can get a very good clinic overview on demand. I was very happy to see that all sites said they were very likely to recommend this database to other high-risk foot services. In terms of challenges, with any data collection project, it is going to always come down to time. And it's time in entering the initial data, but also time in remembering to keep the data and the outcomes updated. And one of the sites here has, given some solution in that, first of all, there needs to be a little bit of protected time for data collection, but also it should be shared across the team. So it's not up to one person to just be, entering all the data in one session. So some of the ways that I think we can overcome challenges is first reflecting on the culture at the moment in terms of clinical care in high-risk foot services, but also more generally. So we are in an unfortunate position where there's a push toward needing to collect data, but I guess the systems in which to do that are not quite up to speed. So there is usually double handling of information, one for clinical care or clinical notes, and the other then for the data collection process. Some of the hospital systems are more geared towards inpatient analytics, and through data coding, it's actually relatively easy to access data we need for inpatients, but in the outpatient setting, those same systems just aren't available. And it's understandable that we'll prioritise the immediate care of the patient in front of us over going away and entering data. And this leads to this mentality of, look, I'll save a bit of time now because there's another patient in the waiting room, and I'll do that bulk data entry, down the track. But the problem is that becomes, I'll do it at the end of the day, to the end of the week, to the end of the month. A lot of services fed back when we launched the standards of accreditation that Standard 8 was just not able to be achieved. A lot of services lacked support resources or tools to be able to collect data in a logical, efficient, and meaningful way. And so this is really where this project came from. Some, although I'd have to say this is fairly rare, think it's better for us to not know some of the outcome data because obviously if you know the outcome data, you need to do something about it. But I think this is a minority for sure. A lot of people have this mentality of waiting for, or they've been promised a perfect solution. And whether that's integration of clinical notes with data collection, whether that's new IT systems, whether that's adapting the data set to be perfect for their local needs, my message is that the systems that we have in place are very adaptable, they're future-proof, the data is extractable and importable into other systems. So let's start collecting data now, and as we perfect things in the future, we can upgrade that with the times. But if we wait, we'll be waiting years and years and nothing will have started. So some of the strategies that I'd like to talk through about especially the time aspect is first of all, setting a target for your site. Are you going to be able to collect all the new episodes of care as they occur? Or are you going to, have to come up with a system by which you're capturing a representative cohort? Now, certainly we would hope that most services are able to put all of the diabetes cases into the database. And looking back to what the services that are participating so far are entering, they're entering about 1.6 new episodes of care per week. And we know that those are taking about 17.5 minutes to enter. So each week, the service has dedicated 28 minutes to data entry. Of course, that's not taking into consideration the setup process, which is more time consuming, and the occasional update as it ulcer heals or is amputated, for example, so some of the outcome data. So thinking about the 28 minutes and how many clinicians are in your service that might be able to then enter data, that might be 2 or 3 clinicians. So divided by them, you've got 9 to 14 minutes per clinician of data entry per week. So, is that an achievable goal? And I think it's very important to involve the whole team in the benefits of data collection. So, they don't want to just be putting in the dry data entry side. They want to also be seeing what's coming out the other end. And that's with respect to the audits, ultimately the benchmarking, but also the opportunity to be involved in a research project. And a lot of sites have entered the clinicians that will be involved with data entry as associate investigators on the project. I would definitely encourage that each clinician enters the initial data on the day of review rather than waiting to do that as a bulk entry. And it's just much more efficient that way. And it breaks it up so that you're not sitting there for a couple of hours trying to catch up, once a month or whatever the case may be. And also, it might be an idea to focus on outpatient data collection, at least initially, so that it's a little bit more disruptive on an inpatient ward round to be trying to update things. But I think in the outpatient setting is really where this would be most useful. We use our interdisciplinary clinics and ward rounds as an opportunity to check on the records and make sure that there's no missing data. So there's definitely useful tools for that. And you can color code the little kind of dots for those that are familiar with REDCap as being incomplete or unverified. And that is a quick flag that, you need to go in and fill something. Or you might need to simply update to say an ulcer's healed or an amputation's occurred. So by doing that as you go, and for us, that's using iPads as we're walking around, that can be very useful, and it distributes the burden of data collection as well. Certainly, each site is going to need a data hero, someone to run the quality checks on occasion, and just to make sure the team's up to date with their data entry. And what I really hope to see over the next year is that we're building a community collaborative group where we're able to share what works, what doesn't work, and learn off one another. So this is the audit tool. The audit tool is free to participating services, and it's built into a spreadsheet on Excel. So it's something which is definitely accessible to everyone. You don't need special software. And from the time of extracting data from REDCap to actually getting the report, it's about 5 minutes. So I think it's really going to be a game changer and certainly help services in achieving standard 8 of accreditation. You can see there's a large number of tables that come out of the audit. Today, I'm going to show you some of the clinical information, but there's also management and outcome data, which isn't quite, mature enough to show you today. So again, a quick shout out to the 5 live services that contributed to this presentation data pool. And on the person level, we have 160 people represented. The average age 64, 3/4 male, and a relatively small portion at this stage, Aboriginal and Torres Strait Islander, although as the project expands, we hope to see that number increase. The majority have type 2 diabetes, average duration 18 years, HbA1c 8.2%. The main macrovascular complication represented is, of course, peripheral arterial disease, in terms of microvascular complication, peripheral neuropathy. And what's quite impressive, I think, not necessarily in a good way, of course, is that 72% of the cohort have had previous ulceration, and 40% have in fact had a previous amputation. So this is a very high risk group. With the service level data, we have 167 service events. The majority of these have been referred from within the hospital, in the yellow there, and about 1/3 from general practices or medical centres. That's again reflected here by referring clinician being most commonly general practitioner. And then, we have a split here of vascular surgeons and podiatrists being the second and third most common referrers. And in terms of telehealth, we do have a small uptake there at the moment. Ulcer data, there's 221 ulcers per the 160 people. And you can see the characteristics here with respect to location, plantar or non-plantar aspect. So duration being 28 days at the time of initial assessment by the High Risk Foot Service, and the precipitants there most commonly acute trauma, as well as chronic trauma or deformity related. 23% of ulcers were recurrent at that same site, and the initial areas are actually generally relatively small, as are the depths, but still 1/5 are probing to deeper structures. The majority are neuropathic in etiology, and about half are infected. So the Wi-Fi amputation risk is then represented here. And you can also see the SINBAD classification, which is automatically calculated per ulcer. And so those that are scoring 3 or more are considered severe ulceration. So that's, you know, 1/3 to 1/2 of the cohort. Charcot foot module. Why did we bother to embark on this? Well, it was actually, again, driven by feedback from services. A lot of services felt that we were covering ulceration relatively well, but the obvious gap then was Charcot foot, and I couldn't agree more. And we needed a standardised way of collecting data nationally rather than us all embarking on our own data sets that wouldn't then eventually talk to one another. So this is going to be an invaluable platform for future research, given the rarity of Charcot foot, knowing what sites people with Charcot foot are being managed at and how they're being managed will be great for not only retrospective research projects, but even prospective research project establishment. We had a tried and tested data set that we've been using at St Vincent's, and that's also been used as part of the Crusades multi-centre RCT. And this was really what the data set was based off, but certainly adapted and changed. I reached out to Professor William Jeffcoat, who I certainly look up to as the clinical lead of the NHS National Diabetes Foot Care Audit, to see what he has been using with respect to data collection for Charcot foot. And certainly there's nothing that's well established or easily adaptable in the Australian context. So we sought input from the Scientific Advisory Committee, as well as the Foot Network Consultation Committee that's formed by clinicians from high-risk foot services across Australia, predominantly podiatrists and endocrinologists, as well as orthopaedic foot and ankle surgeons who had a particular interest in Charcot foot. And what we've come up with is a series of clinical fields as shown here, predominantly dates, precipitant, whether there's previous or recurrent Charcot, deformity and skin integrity as a sign of severity of presentation, the temperature difference between feet, imaging modality used for the diagnosis and monitoring, and then ultimately their classification at presentation being staged using modified Eichenholz, and then Sanders and Freiberg for the sites. And you can see per record, you can have any combination you want of ulcers and Charcot that are all being monitored with respect to their individual outcomes. So the management and outcome fields, some are shared with the ulceration data set. So for example, interdisciplinary input, offloading, footwear hospitalisation, but then there's some that are unique to Charcot, such as use of anti-resorptive therapies, use of offloading surgeries or reconstruction, and the outcomes being consolidation or amputation. So a quick summary here, the Australian Diabetes High-Risk Foot Service database is certainly here, active and up and running. And it is all in the numbers. And for that, we need your collaboration and your support. So please reach out if you haven't already joined. The services that are already participating have expressed satisfaction with the ethics, governance and data collection processes. And there are some challenges, but like I said, I think as a community, we will be able to address and work through these. What we do have now is efficient tools to enable service audit and ultimately benchmarking. And these tools are readily available to services and they can do audits on demand. And finally, the database is built to last and evolve. And the Charcot foot edition is a good example of this, but certainly jump on board now. And no matter what the future brings, we'll be ready to take it on. So thanks very much, and I look forward to your questions.